I'm Dr. Riestenberg from Coastal Fertility, and today we're here to talk about IVF and pre-implantation genetic testing for aneuploidy, or PGTA. I encourage you all to ask any questions that you have as we go. Holly is here with me and she'll relay them to me and we can answer them real time. And otherwise, I'm just basically going to talk through a little bit about IVF and the possible addition of PGTA to your IVF cycle. So first of all, who do we consider IVF treatment for? It's really, our most aggressive fertility treatment option, oftentimes the most effective treatment option, but that does depend on your particular circumstance. It can be used to overcome issues of egg issues, male factor issues, and then more subtle fertility issues of fertilization, etc. It's also the best treatment option for many patients who have previously had permanent sterilization surgery either on the female or male side. So if you've had a prior tubal ligation surgery, it's a great treatment option. And for patients who have a male partner with a history of a vasectomy, it's also a great treatment option for some of our same-sex female couples to undergo what's called reciprocal or co-IVF, where one partner undergoes the egg retrieval and then the other person has the ability to carry the pregnancy. So there are a lot of applications and utility for IVF, and it really is very individualized. So just to know, today I'm going to be talking about this in generalities, and this should always be a really specific conversation tailored to you, between you and your doctor, but I just want to give some general information today. So in general, IVF again is one of our more aggressive fertility treatment options. Some patients will be best off moving directly to IVF, although other patients will start treatment with, our kind of milder treatment options such as fertility medication for ovulation induction with timed intercourse, or fertility medication for controlled ovarian hyperstimulation and intrauterine insemination, or IUI. And if those are failed, then move on to IVF potentially. I tell all my patients that IVF is a treatment option that takes about 2.5 to 3 months from the time we start until the time you're hopefully pregnant. That timeline can be variable again, but in general, that's about the timeline we're looking at. The first month of that treatment is definitely the most intense period of time. And that's when the embryos are created. So the first month is embryo creation, and then the second 1.5 to 2 months is generally waiting for your cycle to return after an egg retrieval, and then preparing your uterus and putting an embryo back into the uterus. So the IVF stimulation itself, again, takes about 1 month. We typically start off that stimulation with about 1 to 2 weeks of hormonal preparation of the ovaries, typically either with oral birth control pills or oral estrogen tablets. And I know that birth control pills sound like a totally counterintuitive thing to begin a fertility treatment with, but the purpose of either the birth control pills or the estrogen tablets, or in some cases other medications that prepare you for your IVF cycle, are that when we look at the ovaries at baseline, all of the different follicles, which are the fluid pockets that hold the eggs, they're all at different stages of development. They're all different sizes. And if we started your stimulation medications when your ovaries had a bunch of different sized follicles, we would end up only growing the largest ones. So we'd end up with 1 or 2 winners. And I don't want 1 or 2 winners. I want ideally a 10-way tie if possible. So that early hormonal preparation is really what brings all those follicles behind the starting line, gets them to be all nice and small and similar in size, so that when we start your stimulation medications, they hopefully all grow together synchronously. So that's the goal. So we begin with the hormonal preparation. After being on that for about 7 to 14 days, we then have you go off the hormonal oral medication and start your injection medications. The injection medication protocol, again, can vary quite a bit from patient to patient. There are multiple different protocols that we may use for different reasons for different patients, but generally, in general, it's a combination of 2 to 3 injectable fertility medications that are administered subcutaneously, so in the skin, in your tummy, just under the skin. And your nurse will teach you how to do that through videos and in-person instruction. I've never had anybody not make it through. So even if you're needle phobic, I promise we can get you through this process. So the hormones that you're taking, the injectable fertility medications, are just synthetic versions of the same hormones that your brain makes naturally to grow a follicle in your ovary each month, but we give them to you at higher doses so that instead of only growing one follicle, we grow as many as we can. So you take those injectable fertility medications for, on average, 9 to 12 days. And it's during those 9 to 12 days that you're in the office very frequently with us, roughly every other day for ultrasound monitoring and blood work. So that's definitely the most time-intensive period of this whole IVF treatment. The purpose of those frequent visits are for us to monitor how your ovaries are responding to the medication so that we can make adjustments in your medication dosing. We know when you're ready for the egg retrieval, and it gives us an idea of what we can expect at the time of egg retrieval. So after about 9 to 12 days on average, you'll be ready for your final trigger injection, and that trigger is what gets the eggs ready for retrieval. So the trigger injection can be one of 2 types of triggers. We use what's called a Lupron trigger in the vast majority of our patients. We do that because it is the safest kind of trigger for the vast majority of our patients and really reduces and essentially eliminates the risk of ovarian hyperstimulation syndrome. But your doctor will choose the trigger that is best for you. That trigger is administered, and then your egg retrieval occurs 36 hours later. So 36 hours later, you come to our Mount Pleasant, Charleston area office. All of our patients from Myrtle Beach to Lexington to Savannah all travel to the Charleston office for their egg retrieval. And although this can be a little bit less convenient, the purpose behind this is that our model is really to have one centralized embryology lab so that we can pour all of our resources into that embryology lab and get the best outcomes for our patients possible. So it really enables us to have the top quality, culture systems, have really our expert embryologists there who are all, using the same standardized protocols. We monitor our outcomes closely. We do, meetings every quarter to review our outcomes and make adjustments to get the best outcomes for our patients possible. So you travel to Mount Pleasant that day. Your whole visit in the office that day is probably in the range of an hour and a half to 2 hours. The egg retrieval itself is performed under IV anesthesia. So you will be fully sedated and comfortable with medications through the IV. But breathing on your own. The eggs are all extracted through a transvaginal procedure using a transvaginal ultrasound. The ultrasound in the operating room has a small needle that runs along the top of the ultrasound, and we use that to poke through the wall of the vagina and go into each follicle that has grown and suction all the fluid out on both sides. All of that fluid goes into little test tubes. Those test tubes get handed off to our embryologists, who are the lab specialists, and while you're still asleep in the OR, they're actually looking through that fluid to find all the eggs. So that day, you'll recover with us for 20 or 30 minutes after the 10-minute procedure, and before you go home, we'll know how many eggs you got. Okay, that same day, we will either use partner or sperm donor sperm to then fertilize any mature eggs that we have retrieved. Typically about 75% of the eggs that we retrieved are mature, and the mature eggs are the ones that we can attempt to fertilize. We do almost exclusively what we call intracytoplasmic sperm injection, which is where our embryologists look under the microscope and select the best quality sperm. They're shaped more normally, moving normally. select a good quality sperm, and then directly inject that sperm into each mature egg. So then you guys go home, you recover. Most patients honestly just need that 1 day of their egg retrieval off of work or any other responsibilities, and then do very well after that. Each day after the egg retrieval generally improves, and your period generally comes in about 7 to 10 days, and by that time you feel totally back to normal. During the week following your egg retrieval, you will be receiving updates from the embryology team about embryo development. So the day after the egg retrieval, you'll receive an update about how many of the mature eggs were able to be fertilized successfully. That's again usually about 75% of the mature eggs, the ones that we attempt to fertilize, actually fertilize successfully and become what we call a 2-pronuclei embryo. And then from this point, there is quite a bit of variability. So for some patients, we will freeze those embryos on the first day of development at that 2-pronuclei stage, and then prepare for a frozen embryo transfer. For other patients, we will grow their embryos in the lab for 5 to 7 days, and then either freeze those embryos at the blastocyst stage, which is what we call it when they make it to 100 to 200 cells of growth by 5 to 7 days of growth in the lab. We may freeze them at that point, or we may do a biopsy for pre-implantation genetic testing for aneuploidy, which is what we'll talk a little bit more about in a few minutes here. So we may do either of those or something in between, which may include a fresh embryo transfer. Fresh embryo transfers we generally will perform on day 2 or 3 of embryo development. And whether you're a best candidate for a fresh or frozen embryo transfer, again, is really unique to you, and something that you'll talk in detail with your doctor about. But since today we're going to talk a little bit more about PGTA, let's talk about those embryos that grow in the lab for 5 to 7 days. So after 5 to 7 days of growth in the lab, about 50% of the embryos, the 2-pronuclei embryos, will make it to the blastocyst stage where they've multiplied and divided into a ball of 100 to 200 cells. And at this point, we can already tell which area of the embryo is going to become the baby and which area is going to become the placenta. So I actually have a little watercolor here in my office of a blastocyst embryo. So this area here is what we call the inner cell mass. That's the inner cluster of cells that's going to be destined to become the baby. And then this outer layer of cells here is our trophectoderm cells. Those are the cells that are destined to become the placenta in the future. This outer halo here is what is called the zona pellucida, and that is the shell of the embryo. If you didn't know, we humans have shells too. So that's a kind of little watercolor of what a blastocyst embryo looks like. So PGTA, or pre-implantation genetic testing for aneuploidy, is an optional test of blastocyst stage embryos. There are pros and cons of this test, and this is something that really needs to be discussed in detail with your doctor. The procedure to do PGTA is where we basically will biopsy, and by we I mean our highly qualified embryologists. They laser a hole in the outer zona pellucida, the shell of the embryo, so to enable them to do a approximate 4 to 6 cell biopsy of the trophectoderm cells, the cells of the embryo that are destined to become the placenta. And those cells are then sent off for genetic testing. We use a genetic testing lab called iGenomics. There are multiple different genetic testing companies, but essentially that biopsy from each embryo is sent off to the genetic testing company. And then the embryo itself is frozen and remains at coastal fertility. Those cells are then processed at the genetic testing company, and the goal is to determine if the embryo is genetically balanced with 46 chromosomes, like you and me. It is able to rule out large chromosomal abnormalities, so extra chromosomes, missing chromosomes, or extra or missing portions of chromosomes of large size. So that is the goal of the test. The test can also tell you the genetic sex of the embryo as well. So the caveats to this test are that it's not a perfect test. And by the nature of the test, that we are biopsying an area of the embryo that is destined to become the placenta and not the baby itself, we know that there is a baseline 2% chance that the placental cells do not identically represent the fetal cells, the cells that are going to become the baby. Additionally, the expertise of the embryologist performing the biopsy is likely very important, as well as the genetic testing company. So this is something that there's been a lot of research on, what patients benefit most from doing PGTA. There can be applications both for young and older patients. And again, this is really a nuanced discussion to discuss with your doctor. But essentially those cells are sent off for testing. The genetic testing company generally gives your doctor the report within about 2 weeks of when the cells are sent off. So generally about 3 weeks from the time of your egg retrieval. And then your doctor will give you a call with those results and review them with you. There are a couple of different outcomes of the results, more than you might think. So there is normal, which is called euploid, meaning that the embryo has 46 chromosomes, which is normal. There is abnormal, or aneuploid, meaning that the embryo has extra or missing chromosomal material. There is also something called mosaic, which means that there are some cells that appear normal and then some that are not normal. So it's somewhere in between normal and abnormal. And those are actually graded as a low-level mosaic, where they feel that most of the cells are normal with maybe a smaller portion of abnormal cells, as well as high-level mosaic, where the majority appear abnormal and there's a smaller portion of normal cells. And then finally, we may get a no result or no DNA detected. That's pretty uncommon, but it does occur. So all of those potential possibilities can occur. The rates of those outcomes, particularly the mosaicism and the no result or no DNA detected, are clinic and lab dependent, and I encourage you to, again, talk to your doctor about that specifically. So we really look at PGTA as a prioritization tool. We prioritize the transfer of euploid embryos over mosaic embryos, and currently we do not transfer aneuploid embryos. That's something that really has not been published in the literature, and safety data are not yet totally available for that, but research is ongoing. So that is a little bit about IVF and PGT. I think I'll just kind of close to say that if we do end up with a genetically normal embryo, we know that pregnancy rates in our lab at Coastal Fertility are generally in the range of 60 to 70% with a transfer of one euploid embryo. So very good chances of success. And that again is dependent on the clinic. The chances of success with a euploid embryo are very minimally affected by the female age. So the effect of the uterus on success rates is much, much less. We do know now from more recent studies of egg donor IVF that patients who are in their mid-40s and upwards may have a slightly decreased chance of success even with the transfer of a euploid embryo. This is a minor decrease, and overall we still see very high success rates. We think that that may be attributable possibly to the uterus, but also possibly to the metabolism of the embryo, that although they're genetically normal, there may be some metabolic components that are not quite normal. So overall though, great success rates with the transfer of a euploid embryo. PGT can be a great tool in some circumstances, but it's certainly not a one-size-fits-all. So I really encourage you to have this conversation in detail with your doctor, which you will. Okay. I'm going to go ahead and check in and see if we have any questions at this point. That was a lot of talking on my end. No questions today. Okay. So I think those were all the points I mainly wanted to convey today. This is certainly a very nuanced conversation, and your doctor will come up with a plan specific to you. At Coastal Fertility, we really believe in patient-centered, personalized care. And so, my goal today was to provide some general information but certainly this is something that we want to tailor to you to optimize your chances of success. Oh, I will say, actually, there was one thing I wanted to show everyone. So something I encourage you to do, whether you're coming to us or going elsewhere, how do you know what your chances of success with IVF are? There's one website that you may not come across if you're doing your Google search. It's called SART, the Society of Assisted Reproductive Technology. That society is a U.S. society that collects data on IVF success rates from clinics across the United States. So 85% of all IVF clinics in the U.S. and really all clinics of significant size and good reputation report their data to SART. And this data is published online for all to see. So if you go to sart.org, you're going to be able to see both national averages as well as clinic-specific success rates. So you go to the general sart.org website. Let me talk you through this so you know how to find it. And it's pretty easy to navigate. There's a tab called IVF Success. And then the 2021 National Summary is the most up-to-date data that we have because it takes some time for patients to go through IVF and then get pregnant and deliver. But in 2021, almost 370,000 IVF cycles were done and reported to SART in the US. And success rates, the first graph that you'll see there, because there's a lot of information, that first chart is really what you need to look at. And what we really care about is the chance of live birth. So that last row in that first chart, you'll see that chances of live birth are broken down by age group. And that the most important thing in predicting success with IVF is female age. So under 35, for example, the national average success rate with IVF is 54%. But you can, fortunately, also look up Find a Clinic. So that same tab from the main page, you can find a clinic. You can type in Charleston to find us, since that's where our main embryology lab is. And you can look at all of your local clinics as well as national clinics and what their success rates are. So under 35 at Coastal Fertility, we're really proud that our live birth rate is 72%. So we do quite a bit better than the national average. We're very proud of that. We like to know that we're providing the very best care that we possibly can to all of our patients. And again, that I always tell my patients is a little bit what I do, what the doctors do. And it's a big part what our embryology lab does and how much energy we put into optimizing the embryology lab. So I encourage you to check out sart.org for more information and, reach out to us. We would love to see you. Okay. It was nice speaking with you all today. Take care and good luck in your fertility journey. Bye.